This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the surgical treatment of mitral regurgitation. With us today, we have special guest, Dr. Clifton Lewis, who's Chief of Adult Cardiac Surgery at the University of Alabama in Birmingham. And later on, we'll be joined by our very good friend, Mustafa Ahmed, Director of the Interventional and Structural Program, also at UAB. So, Clifton, welcome to the podcast. And I know we're going to learn a lot today, you being a premier surgeon in the Southeast. So we know that mitral regurgitation occurs with increased frequency as part of the degenerative changes in the aging process. As a matter of fact, the degenerative mitral valve in an industrial nation is estimated approximately 2 to 3% of the population. And by degenerative, we mean prolapsed mitral valve or myxomatous mitral valve, a flail or floppy mitral valve, or the disease of Barlow. We have also other reasons to have mitral insufficiency, and we'll discuss them briefly toward the end. And those include the ischemic mitral regurgitation caused by a heart attack. We'll discuss also the infective endocarditis or infection on the mitral valve and the rheumatic heart disease that we see in developing countries. But before we get too involved with the mitral regurgitation, Clifton, I'd like for you to kind of describe to us and explain to us, when we talk about the mitral valve, we talk more about, more than just a valve. If you could describe to us what is the mitral valve apparatus and how does it work when the heart contracts and relaxes?
Well, for the most part, all the valves in the heart are reasonably passive. The mitral and the tricuspid have some active components to them, the papillary muscles. And so they are influenced by ventricular function to a good bit more than, the semilunar valves are. The mitral valve is part of the endoskeleton of the heart. It's got two leaflets, the posterior and the anterior, and they connect through the chordae tendineae to the papillary muscles. There's a lot of variability in terms of the number of the papillary muscles and the number of the chordae, but the number of leaflets is always constant in really both the mitral and tricuspid valves. And that's one of the reasons why their mitral valve disease and how you treat it surgically is really dictated by not only the anatomy and the pathology of the mitral valve, but how it relates to the ventricle and what the etiology of the disease is. Most people, when they think about mitral valve insufficiency, for example, they think of it as sort of like a one disease, like a box, one black box. And so all mitral valves ought to be repaired. And that statement would be true for degenerative disease, but it is in no way true for other forms of mitral valve disease. An example is ischemic mitral insufficiency. And that's because, again, the mitral valve is not just a passive valve. It's really part of the left ventricle. The other part of it that's important in terms of its structure and, its position in the heart is how close it is to the aortic valve, how close it is to the bundle, and how it is to the circumflex coronary artery. All those things are really important when you get to operating on the mitral valve.
So now that we know a little bit more about the mitral apparatus, Clifton, let's see if you could explain to us a little bit what happens with in the degenerative mitral valve, what happens to the leaflets and the chordae and so forth.
So for the most part, degenerative disease has to do with what they call excess leaflet mobility. You have too much leaflet tissue typically. You have disease chordae tendineae, and really degenerative disease is sort of a spectrum. It's based on fibroelastic deficiency disease, which tends to lead to elongation of the chordae tendineae and weakness of them, and then they'll rupture. And in its simplest form is just mitral valve prolapse or a mitral valve flail, and it tends to be limited to a single portion of one of the leaflets. As you progress along that spectrum and get more what they would call myxomatous degeneration of the mitral valve, and then the far end Barlow's valve, you add more and more segments of disease. You tend to have more an increased volume of leaflet tissue, and when you get where there are multi-segment prolapses and multi-segment excess tissue, then the disease just becomes more complex in terms of treatment. And what I mean by that is operative treatment. What I mean specifically by that is operative repair of the mitral valve. And that, I think, Alain, you talked about that increasing in its incidence, and I don't know if that's true or not. It may be. Certainly, there are more cases that are discovered. Whether that's because there's an aging population and more people live to see their valve degenerate, or it's because we have better screening for people and we find more people that have mitral valve disease, I don't really know. But certainly the number of mitral valve operations for degenerative disease is increasing in the United States.
Yeah, very good point. So Clifton, in the 60s and 70s, I mean, they did mitral valve replacement for this disease, for the degenerative mitral valve. It was quite common operation, but high mortality. And here comes in 1969, Alain Carpentier in France, who started performing some repair of the mitral valve, the so-called French correction. Can you tell us a bit about that?
So I don't know for sure, but my guess is that the reason he did this is probably motivated by two things. One is that there was people were repairing rheumatic disease, and the simple repairs were commissurotomies. The first real valve operation in the United States was a finger fracture for rheumatic disease, and so he would have been schooled in these repair techniques for rheumatic stenosis. And also, we had really crummy valve substitutes. There were really not very many any good valves. Mechanical valves were prone to catastrophic failure back then. Coumadin and following it was in its infancy, and it was dangerous. And tissue valves had very poor durability. And so my guess is those are the two things that motivated him to want to try and figure out how one could repair a valve and leave you with your native tissue. And what he did is he took out the disease sections of the valve. I mean, the classic Carpentier technique was a quadrangular resection of a prolapsing or a flail posterior leaflet. And then he would do a reduction annuloplasty at the base of that to bring the edges of the annulus where you had resected down on the quadrangle together, and it pulled the tension off of the annulus, and then he would support it with an annuloplasty ring or band. As time went on, he added to that, and what he would do is he would take non-diseased chordae, he would transfer those to other areas, he would shorten chordae, but it was all based on what they call resectional techniques. He's really the father of modern mitral valve surgery, and everything we know about it is leveraged off of his early experience and his early techniques.
So it looks like he was trying to reconstruct a normal valvular anatomy with extensive leaflet resection, chordae manipulation, as you mentioned, and this kind of rigid annuloplasty is basically a rigid ring around the annulus. But obviously, it was kind of a difficult operation. It looks like not everybody could do it. It looks like the penetration of the technique was maybe 50 to 60% across the United States, and the results were not always optimal, aren't they?
Well, that's true, and there are a lot of things that drove that. I mean, one of them is concurrent with all this was, I mean, people's increasingly improved understanding of cardiopulmonary bypass and myocardial protection. So the guys that did any of these operations, didn't matter whether it was a replacement or a repair, they had to be not only accurate on the first time, they had to move with a lot of dispatch, or else they would end up with a dead patient, because the heart would die, because you just couldn't leave it stop for as long as we can leave it in the modern era. Remember, they didn't have the same stitches that we had. They didn't have the same rings that we had. They didn't have the same, even some of the fabrics that we use nowadays to coat some of these rings did not exist back in the 70s. Those all those things that had to be developed, and all these guys were these old guys, the giants of heart surgery that would sort of stand on their shoulders. Those guys had to think all those things up and then send it to an engineer, and the engineer had to develop it. And so I think that he mastered it, and he was an artist, but he couldn't I don't think he could teach it as well as one might. You couldn't see what he was doing as well as you would want to, because you couldn't just visualize it. But there was also, there wasn't a whole lot of, you might call scientific or academic language that surrounded the repair of the mitral valve. A lot of it was sort of like painting a picture. I mean, there's some people that can just sit there and they can paint that picture, and they're really good at it. They might not be able to teach you how to paint it. I think there was a challenge teaching those techniques. Some people were really good at it, some people weren't. So I think it was a combination of the need for technological advancement and the need for a language to be able to explain and quantify what you're doing. He tried. He had they called it the Club Mitral, and they would people would come to France, and he would teach people, and he exported it, and a lot of people did learn for degenerative disease for decades in the world, not just the United States, was stuck somewhere around 45 to 46, 47%. It has increased recently. Part of that's because people watch what you do, but part of it's because, and I know we're going to talk about this in a minute, there were, some new techniques, the American correction, which added to it, but also there's a developing language around mitral valve repair and a standardization of what you're actually talking about. So you can compare apples and apples and oranges and oranges.
That's a good point. There was some problem with poor long-term durability. I mean, you have maybe 20 to 30% of the patient that came with, recurrent mitral insufficiency, and there's some problems you see sometimes with this systolic anterior motion, that comes and blocks the outflow of blood across the outflow tract because of this rigid, ring. And even I had a patient actually earlier this year that necessitated a reoperation because of post-op mitral stenosis that developed, that was quite common with this type of repair, that he had.
Well, I think, Alain, there's a couple of things about that, and I didn't mention it, and you bring up a good point, is systolic anterior motion of the mitral valve and mitral insufficiency, late stenosis. Those are, part of that is an increasing understanding of how resectional techniques and repair techniques predispose one to systolic anterior motion of the mitral valve, or predispose you to excessive scarring and later stenosis, particularly with rigid downsizing rings. I think that TEE had to develop before people truly understood. I mean, I remember the days before TEE, and you'd squirt saline in the ventricle and it looked good, so you were done. And you had no earthly idea whether the daggum thing worked afterwards, but it worked when the heart was stopped, so that way everybody was happy. So, now that we have TE, first thing we realized is you'd come off and you had MR, but you couldn't figure out what the hell did I do? It was looked good, and then I closed, and now it's not good. So you learned at some point that your failure may have been related to SAM. But then you had to figure out, well, if it's related to SAM, how am I going to prevent SAM? And, the difference between an 85% repair rate for a degenerative disease and a 98% repair rate for degenerative disease is really understanding how do you avoid getting SAM. And that is really important. Plus, it will just understanding how you're not going to get SAM is going to reduce your early reoperative rates as well. And early to intermediate development of mitral stenosis is really a different matter. That really has to do with how aggressively one downsizes the ring. I mean, it can cause SAM, but most of the time that we ended up with late mitral stenosis has been related to aggressive downsizing, which in our sort of modern era practice is related to treatment of dilated cardiomyopathies more than it is degenerative disease.
Great. Well, let's go ahead and talk about this American correction because obviously it changed a lot. And as you mentioned, in the late 1990s, we had really improved imaging capabilities with TEs, 3D echoes, and a greater knowledge of really all the intricacies of this mitral valve motion and function. And one of the pioneers, I think, of that work of the American correction was really Dr. Gerald Lowry at the Bakey Heart Center in Houston. So can you explain to us a little bit what was some of the great innovation that he developed and that is implemented today?
So what he theorized, hypothesized was that the less you resect, the less likely you are to injure the valve. And so what he tried to do was what they would call respect the mitral valve in the tissue as opposed to resect it. And so when he had either flail leaflet or chordal elements that were too long, he would either transfer the chordal elements, or once Gore-Tex suture became available, PTFE, he became a proponent of chordal neochordae tendonae, and they would place those. And the idea is that more tissue, you need less constriction on the downsizing on the leaflet, and so he put in big bands and big rings, and then did primary leaflet repairs with either chordal transfers or chordal addition, and that helped in one way with the issue with systolic anterior motion of the mitral valve, because if you over correct in terms of downsizing on a ring, then you will typically crowd the orifice of the mitral valve, and particularly if you have a big posterior leaflet, it'll almost push the anterior leaflet into the slipstream of the outflow tract, and then you'll get SAM. One of the problems with that is, and one of the things that people would argue about it was, well, number one, you will leave some diseased tissue, because you're not resecting it. Number two, you got to put really big rings in, and if you put in too small a ring, then basically the height of your posterior leaflet is going to be so high it will push the anterior leaflet in the outflow tract, and then you're going to get SAM and SAM-mediated MR.
And they're flexible rings, right?
Well, I mean, you can use a flexible ring in a Carpentier repair. You can use a flexible ring or a rigid ring in the American correction. And they're adherents to flexible rings and bands, and they're adherent to rigid rings and bands. Very few studies really show that one is better than the other, and a lot of it has to do with surgeon variability, and then also when they do those studies, they're throwing in all kinds of different etiologies of disease. So, our way of thinking is that if you catch the trigones, and you got to catch the trigones in your bands, and you can do an incomplete ring, and it'll work as good as a ring. Is a ring a bad thing? I don't think so. Not in degenerative disease, but is it necessary? I don't really think so either if you catch the trigones. If you're talking about a downsizing annuloplasty for a non-ischemic cardiomyopathy, where basically you're just cinching the valve down, almost everybody uses complete ring because the recurrence rate MR is higher if you don't. And then there are people that argue on either side about rigid or flexible. And then when you get to ischemic, there are people that argue about size, shape, rigid, flexible rings. My personal opinion is a ring's not a good idea in ischemic disease. You ought to replace it, and I know we're going to get into that at some point. But there are so many different things that are variable when you repair those. And again, this is where you deviate from science and you get into the art of the repair and how you make it fit together and work. I think that one of the problems that happens with surgeons and even with cardiologists is they get really dogmatic about what technique you ought to use. I mean, they can get fighting as much as the Republicans and the Democrats do these days. I mean, and
I don't know if that's possible, Clifton.
Well, I think it is, and they act just as silly, And so, I mean, my personal opinion is there's a lot of ways you can do it, and I like to take a little bit from column A and a little bit from column B, and I like to combine the repair techniques of the American correction and then the French correction. And the idea behind them is, if you put them together, is you can get rid of diseased tissue, you can reduce the height of the posterior leaflet and sort of the volume of the leaflets, but only enough that what you do is you create a situation where 2/3 of the orifice or the area of the mitral valve annulus is covered by the anterior leaflet, 1/3 is covered by the posterior leaflet, and then where they meet, what they call the coaptation zone, is deep enough that it'll close the valve, and posterior enough where they meet that you will not be predisposed to SAM. And McCarthy at Chicago, he is not at the University of Chicago, but I'm blanking on where he's at, but he's in Chicago. He's probably the first person I know that has quantified this in a mathematical way when he talks about repair techniques for degenerative disease. And he's primarily a Carpentier student, so he uses resectional techniques. But really it fits for whether you're talking about the American correction or the French correction. I mean, like I said, we put it all together and we resect, we add cords, we maintain tissue, we upsize our rings. So we really we're kind of a Heinz 57 approach to mitral valve repair surgery. We call ours the redneck technique. Whatever works, you do.
Certainly, it appeared to have simplified a little bit the operation because now it results in about 90% repairability rates, as before it was stuck in the 50 to 60% at best, and certainly for myxomatous valve, the degenerative type that we're talking about, probably in about 100% repairability. Don't you agree, Clifton?
Well, it's close to it. I mean, you will run into some that are, they're degenerative disease, but they're heavily calcified because they've gotten really old. And so you really can't repair those. Now that is being influenced by, non-operative techniques for mitral valve repair like clip and that sort of thing. But, repair rates are a funny thing because again, the first thing you have to do is define the etiology. It's got to be degenerative disease where you talk about this. And then the second thing it's got to be is intention to treat. So there's a fair number of operations that are done on degenerative disease where there's no intention to treat by repair. There's an intention to treat by replacement, and those will skew the repair rates across the United States and the country. But I think that if you were going to be intellectually honest, for degenerative disease, you're in a reasonable patient, your repair rate should be north of 95%.
That's really excellent. And mortality is low. We're talking about 1 to 2%. The rate of recurrence of mitral insufficiency is also very low. You have, with this, basically the repair techniques that we have here have really excellent long-term results.
So, Dr. Bouchard, I'm going to jump in a bit on that. So, mitral valve surgery, as Dr. Lewis has been pointing out for the last 20 minutes or so, is an art form. The problem with it is it's done differently in different places, and it's not, each result, each individual center is not scalable. And so if you actually scientifically do an analysis of every major series of mitral valve repair in the last 20 years that's come out, and you have to remember that to even be a center that's going to publish several hundred mitral valve repairs automatically makes you an outlier. I mean, it already makes you one of those excellent reference centers, but freedom from reoperation is anywhere between, and this is at somewhere between 3 to 10 years, and 1 or 2 a little bit longer. But freedom from reoperation is anywhere between 80 to 95%. But if you look at those series that have had more than 200 up to 1,200 patients in them, and you look at freedom from MR at that same point, the best results at freedom from 3 to 4 plus MR are 80%. And the range is between 70 to 85% for freedom from 3 to 4 plus MR. And it's critical to know that, because mitral valve repair is, for people of decent surgical risk, mitral valve repair offers the best solution we have. But for reasons I know that Dr. Lewis has been pointing out and may have more insight into, and I think other reasons that include the fact that in degenerative disease, the disease of the valve it's inherent to the valve. So even once you've fixed that valve, there's a potential for continuation of the same disease process that occurred. You may see, chordal rupture continue to occur. So that's why those freedom from 3 to 4 plus MR is still only, even in the best of hands and the largest of series is, 80, 85%. Now, if you look at just under 10 years, so if you go to that 5 to plus year range and you take the busiest 3 to 4 centers that have been published recently since 2016, 15, 16, the numbers are actually much higher. So the repair rates approach, like say 95% plus, even higher than that. And the freedom from 3 to 4 plus MR and the freedom from reoperation at 5 years is in these cases above 90, 95%. And I don't know if that's due to the fact that the places that are publishing it have just, really nailed the art of follow-up, or if it's that people are just getting better at that in a few centers.
Well, certainly for degenerative mitral valve regurgitation, it looks like, mitral valve repair is the gold standard, and with low reoperation rates, long-term results that are really excellent, no more SAM, and, I think with very low mortality. So I think the technique is really kind of improved considerably compared to when it first started. Now, we have obviously the different approach to the mitral valve repair. There is the minimally invasive and then the robotic. So, Clifton, how about you tell us a little bit, discuss what is involved with the minimally invasive technique compared to, for example, a standard technique of mitral valve repair?
So, minimally invasive, whatever it is in heart surgery, is really kind of a confusing term, because basically how you define it is whatever you want to say it is. But as a general rule, you would define minimally invasive heart surgery as the avoidance of a full sternotomy. And so and I think that's a reasonable explanation. All of it's open heart surgery because you got to open the heart to get the mitral valve. And really, if you think about it, you do the equivalent operation on the heart. Okay, you're going to end up with a repaired mitral valve, whatever the end point is. The difference between a minimally invasive operation and the standard sternotomy operation is sort of like getting the same present for Christmas wrapped two different ways. Okay, what's really important is repairing the mitral valve. Now, that doesn't mean that a minimally invasive technique is unimportant or not beneficial or anything like that. It means that the most important thing is repairing the mitral valve. And if you get the mitral valve repaired through a sternotomy, that's superior to not repairing it through a minimally invasive incision. And that's, I think, the important point. And we're all assuming we get a live patient at the end of all this. So there are a couple of different minimally invasive approaches to the mitral valve. One is through what they call a hemisternotomy. You can do a mitral valve repair through a limited upper sternotomy and go through the roof of the left atrium. You can do it through a lower hemisternotomy and go through the standard sort of interatrial groove approach. You can do it through a thoracotomy, the right chest approach, and you can do it through the right chest and do it with a robotic assisted approach. And really, I don't do much in the way of minimally invasive sternal incisions or hemisternotomies anymore. And I don't do it because I think it basically just makes it harder without a whole lot of benefit. I like to do them through the right chest, and the reason that you do it through the right chest is a couple. One is you don't have to worry about a sternotomy healing. So if you don't have to do that, then typically recovery rates are a little bit quicker. People like it a little bit better. It's cosmetically superior. You tend to recover quicker. And if you can get really lateral in the right chest, you can actually see the mitral valve really a lot better than you can through a sternal incision, which for complex mitral valve disease, I think actually makes repair a little easier. And whether you use a robot or you don't use a robot when you do the right chest is really a matter of choice. I mean, the way I think about a robot, the appropriate way to think about a robot is it's just a $2 million pair of scissors and forceps and a camera. If you think about it like it's some kind of lost in space guy walking down the road or, some kind of magical thing, I think you'll mess it up. So it's an instrument. You got to know how to use the instrument when it's good and when it's bad. Is there any difference between a right thoracotomy, minimally invasive mitral valve, and a robot? No. You have to use a bigger incision for a minimally invasive right chest approach than a robot. But there's really no fundamental difference because the endpoint you have to achieve is a live patient that's healthy with a repaired mitral valve. And in that sense, there's not a whole lot difference between that and a thoracotomy or that and a sternal incision. We like the robot. The reason we like the robot is we get to see it better. And, I'm getting old enough now that being able to see things is not always easy. And so we have 10 power magnification instead of 3.5. Everything's on the TV. And plus we've done about 1,500 of them, so we're comfortable with the idea, but it would be intellectually dishonest to suggest that there is a significant difference between robotic, minimally invasive, and sternal incisions. Again, as long as you get to the appropriate endpoint, which is a healthy patient with a repaired valve. Now, you could say the same thing about laparoscopic gallbladders. There's really not a whole lot of difference between a laparoscopic gallbladder and a big incision in the belly gallbladder, other than it's a little bit easier on the patient to get over it. I mean, you still have the same endpoint, which is you get rid of the diseased gallbladder. So there's a value to minimally invasive incisions. If you do, but it's not living and dying necessarily advantages. If you do a robotic mitral valve repair, you can have somebody fixed and you can have them up and doing what they want to do in about 3 weeks. If you do a sternotomy, you're out of pocket for about 8 weeks. But 6 months later, all you're going to see is a scar. So it depends on how you think about it, how you talk about it, and the primary problem with the minimally invasive approach is that it's like mitral valve repair, and Mustafa touched on this before. If you look at repair rates and you look at the durability of repair, it's really dictated by the volume of surgery that a guy does on the mitral valve. So the people that do a lot and the centers that do a lot typically do a good job. And the people that don't do a lot don't have as good a results. And that doesn't mean they're bad surgeons, it just means that they don't have the opportunity to learn as well as others. Same thing holds for robotics or minimally invasive. If you have an opportunity to do a bunch of them, then you and your whole team can learn how to do them and do them well. And in that case, it's a reasonable thing. And it's a valuable thing, but it's not necessarily better than a sternal incision is what I'd say.
Well, we've talked a lot about the mitral valve repair, which, really the gold standard for this. But sometimes you don't have a choice. The valve is destroyed, and we'll talk about that maybe with other pathologies, but you have to do a mitral valve replacement. So could you explain to us why is it better to have a repair compared to a replacement?
Well, first of all, there's an observed statistical benefit. Okay, if you look at early, intermediate, and late outcomes of mitral valve repair versus replacement, the odds of being alive and well are better with repair versus replacement at any at any point you choose, whether it's 30 days, 60 days, a year, 5 years, or 10 years. Now we're talking specifically about degenerative disease here because it changes. If you're talking about other pathologies that cause mitral insufficiency, but for degenerative disease, your odds of being alive and well, free from reoperation, are better with a good repair than with a replacement. And I think the way I think about it is whenever, I don't think of it, if I've cured a disease in my lifetime, I don't remember it, okay? I mean, in some ways, when you operate on people's valves, you take one disease from them and you give them a different disease. So you may have a normally functioning mitral valve when you repair it, but you've cut on it, sewn on it, added this, added that, you put a band or a ring in there. It is not what God put there. It is not a normal valve. And it can go bad over time. Mustafa mentioned that disease progression can get you, and other things that will prolapse, but some of this progression and problems is related to what we do to fix it. Same thing holds with a replacement. You're giving somebody a different disease. If you give them a mechanical valve, you got to anticoagulate them, and they're at risk for these thromboembolic events. And the valve can't, even though we say it's permanent, can fail. Tissue prostheses, they fail over time, as you know. So it would be nice if we cured them and that we'd never see them again. And maybe we do a few, but you'll never know that. Basically, you're waiting until whatever your treatment wears out.
Certainly, early on, there was a lot of work, particularly at Stanford, finding out what happens with the mitral valve replacement and cutting some chordae as well as papillary muscle, and really contributed to a lot of the hearts becoming weaker and contributing to left ventricular dysfunction. I forgot the name of the surgeon who was doing a lot of work on it, but it seems like mitral valve repair, you have better survival, you have better LV function. And it's
true. No, it's true. And the other thing is, and so if you have to replace it, if you can preserve chordae when you do a mitral valve replacement, the data would suggest that people live longer and live better if you preserve. And that's because as we started all this, we talked about the mitral valve as part of the left ventricle, and so the papillary muscles don't just support the functioning of the mitral valve. The mitral valve supports the left ventricle. And so when you start cutting all these chordal attachments and replacing the mitral valve, they don't do well. Now, but it gets really complex, as you know, because when you intervene in the natural history of these diseases, really it has a great deal to do with their response to operation. You will see some people that you repair the valve, so you haven't resected anything. And they will develop late severe left ventricular dysfunction. And most of those people probably do that because you've caught them late in the natural history of the disease. That's why the recommendations for when you operate on degenerative MR have changed so much, because we basically were waiting to operate on people, and we were waiting to operate on them because cardiologists did not want to have a person show up with a dead heart from a replaced valve. And what they got was what they didn't want, and they got it because they waited too long. Now, our criteria for mitral valve repair for degenerative disease is severe MR. If they're a healthy person, we operate on them and repair them. If they're an unhealthy person, then they have an interventional technique. But it is driven by the severity of the MR. It is not driven by the other, what you might call secondary indicators. If you wait for a secondary indicator, AFib, LV dilatation, LV dysfunction, pulmonary hypertension,
almost too late.
Well, you rob people potentially rob people of years of their life and quality years of their life. But again, and it even gets more complex, because if you replace the valve as opposed to repair it, then that calculus is not the same. Once you start peeling the layers back on mitral insufficiency, it becomes really complex. And it's not just a repair that's artistic, like as opposed to scientific, like Mustafa mentioned. It's the understanding of mitral valve disease remains opaque. It is not nearly as quantifiable as we'd like to think it was.
This is all important because it leads to the concept of a mitral valve reference center. When we see these patients, I work very closely with Dr. Lewis, and the patients that are sent, that multidisciplinary input from needing so many different types of specialists, and then having different tools available, and then having a discussion about all these layers we just talked about. How bad is the valve actually? What is the indication for operation? And what is the trade-off in these cases? Can we justify doing an operation based on what we see? And then do we feel confident to repair that? And in some cases, what is the correct operation? Is it a repair? Is it a replacement? Is it these are such complex decisions that require so much expertise that the ability to scale this realistically is across every center that does cardiac surgery, the ability to do that is zero. And, one of the large pushes, if you look at the last 10 to 15 years of when should we operate on a patient, and one of the large pushes has been, okay, let's identify these groups, a number of factors such as damage done to the heart, what the heart looks like, and repairability all comes into that equation. And there's probably enough evidence. Remember, none of this is class 1A evidence. Class 1A means we've taken a group of people, we have taken many centers, we have randomized the different timings of operations against each other, and we've found out that one is superior to another. That's never been done. Whether that is ever done in mitral valve repair is questionable. The advent of percutaneous therapies has actually advanced the science of recognition and management of disease. But the surgical, the gold standard surgical trial, when I first moved into mitral valve disease, my dream back then was, are we ever going to see the randomized controlled trial of early surgery versus later surgery? But at no point is anyone trying to wait for a patient that has really high pulmonary pressures, very enlarged heart. That's not the point. The truth is that's often missed due to under-investigation, misdiagnosis, and lack of expertise available to find those. I mean, many of those patients are out there, even by the time people present to us for early surgery, which means people are sending them and saying that early. When we do a nuanced evaluation, we'll find subtle markers of heart enlargement and such, and could have done them before. But if you were to take people really early in the disease process, and you find out they've definitely got severe disease, and then you would take that, not a single marker of major, not ultrastructural, but not a single macroscopic or grossly visible marker of damage is available, then the question is, which one truly is better? When they're so early in the disease, you don't know. And in the US, due to many series that have been published in the last 10 years, it's now a recommendation that for people with severe MR that is degenerative, that in the setting of a mitral valve reference center for repair, which, like Dr. Lewis was saying, means you can achieve that 95% plus, or some people would, when we talk about it, we want to confidently say 99% repairable. You can achieve that. If you can do that, there's enough belief now that this is an extremely appropriate and potentially advantageous way to go. Now, Europe the series published in Europe demonstrate that a watchful waiting approach, which means you take the same patients that are done. There was this big debate. This debate occurs at every major valvular meeting. There's always a early surgery versus late surgery. And there is some prospective data, which means people were watched over time, and they were watched with no damage and no secondary markers of heart disease. It's not the worst thing potentially for someone that comes to you, say they're 30-something years old and they've got severe MR and it's totally degenerative and everything's normal, the heart size, and all. We're going to offer them an operation if we think that is repairable. But, there is some evidence to suggest that if you were to watch that patient really closely over time, they were going to come to your clinic, you were going to follow them up with regular echocardiographic checks. They were so vigilant as to their symptoms that they would turn up on minute one when they had, there's some evidence to suggest that's not necessarily a terrible approach. So at no point are we bringing patients in and saying, you must absolutely have an operation now. There is every single point of data in the whole world points towards this, or you're going to die in a few years. That's not true. What we say is we think only bad things are going to happen over time. We think that in our experience, you can go through this operation very safely and have a repair and a good outcome, keep your own valve. We then believe that the risk to benefit, the 1% trade-off or the less than 1% trade-off for an operation versus the benefits you may get out of it are worth just taking this off the table. And so that's a work in progress. I don't know if we'll ever have the perfect answer to that. But Dr. Lewis, one of my questions to you in this debate is, there's so many papers published on this about why is repair rates in the US or even beyond that, why is it that people are still offering replacements for those patients? What are the societies for someone that came from England, where really specialist work is often funneled to really specialist centers. You don't play, ideally, at mitral valve repair. Why is it in the United States that despite this topic being publicized, that a patient, because remember, a patient doesn't know better. And if you were to do a bypass surgery and you were to ask your surgeon, hey, how many left internal memories have you done? And they were like, well, we do 3 a year. I mean, you're never going to send that patient a bypass to do. But why is it in the mitral valve repair? No one knows better. Cardiologists and teams are not really held accountable for that. The data's not really widely available. How does that work when you as surgical societies discuss how to solve that problem? I think that is one of the biggest problems in mitral valve disease.
Well, I think it's a multifactorial thing why that doesn't happen. First of all, the societies really do encourage, the STS encourages mitral valve repair, and they have they've really driven this increase that Alain talked about from the 40s to I don't know if it's hit 90 now, but it's in the 80s, and that is they've made a real push in terms of education, making it important. They follow the results, they report the results. They don't have any follow-up data about durability or anything, but there's been a really big push for that. And that is to their credit, because it clearly is a better thing to do, much like you mentioned with IMA use, and basically you get scored and graded for that. I think there, the sort of the challenges ahead are, number one, you can play with those numbers by how you code the etiology of the disease, because if it's a degenerative disease and you code it as rheumatic or whatever, then it's not going to fall under the same heading, so you can end up with a higher repair rate. That's one problem, is the data is not pristine or pure, and it gets manipulated. The second thing is access to care and geography. There are places where it's hard to go from one program to another. And that may be because of distance. It may be because of economics for a patient. It may be because of age. I remember when I lived in Florida, we would have people that wouldn't want to drive 20 miles because they just didn't like to drive because they were old. And there was a big difference between repair rates in these two programs, 20 miles apart. And then there is we don't have a single payer system like they do in England, or even in Germany, and places where you have centers of excellence, and certain procedures are driven to those centers of excellence. Would it be nice if you did it? Yes, it would. But if you just look at the proliferation of TAVR programs in the United States, where they were going to, in our state, for example, there were going to be 3 or 4, and next thing you know, they're 15. They're, and that's not all bad. I act like it sounds like I'm saying that's a bad thing, but it is not. It is nice to have access to advanced heart surgery care in your town, because number one, you may need it on an emergency basis, and number two, it is logistically difficult for patients to travel for care. It's expensive and unpleasant. It's hard for them to do. But you will get what you pay for if you go to a place where they do 10 mitral valves in a year. You will not have a high repair rate for complex mitral valve pathology. Is that a good thing or a bad thing? Well, it's good that they don't have to move and they have access to care. It's not necessarily a good thing because they don't get their valve repaired. And then the final thing is that, we're in a volume-driven business. The more widgets that you produce, the more you make. And so it is hard for people to let business go. And, if you find me a heart surgeon that doesn't think he's the best in the world and can do anything he wants to, I'll show you a zebra, because those people are unusual. Most of them really think that they're good at this stuff. And they think that if they can't fix it, then it can't be fixed. And that's just, it's part of the personality that goes into being a heart surgeon is really what you need to be. You need to think that way as a general rule. I mean, it needs to be mitigated in some way. But I think all those complex things drive why it's not as you would like it to be. If it was a world, there'd be, a center in every state doing this, and they'd all go there. But it will never be that way. And that's just sort of the world we live in.
Well, I'm going to go back on the timing for when should we send, patient for evaluation for repair. It looks like, the earlier the better. I mean, it looks like it's best to operate in someone who has severe leakage of the mitral valve with the normal heart function, even when they're completely asymptomatic. It's just difficult sometimes when you have, for example, someone that does marathon running and is completely asymptomatic, and you hear a heart murmur, you do the echo, you see severe mitral insufficiency, normal left ventricular function, of course, with ejection fraction greater than 60%, a normal left ventricular size. It's hard to convince him that, surgery, it's time for surgery right now. I mean, maybe to the point of Mustafa, careful waiting and watching, possibly doing, follow-up every 6 months to a year, getting another study of the heart, looking at cardiac MRI. I don't know. What do you think?
I'm going to weigh in on that. So it's the impossible situation. You get someone that comes to you and they're feeling like $1 million. They're running marathons. Someone's heard a murmur and says, you've got really severe mitral valve disease because of prolapse. We're sending you to see a specialist to maybe get this repaired. They come to you and say, we're feeling at the height of our powers right now. Do we really have to have this repaired? And once again, in the absence of class 1 multi-center, type evidence, the key here is to have an informed discussion, because it's the same marathon runner that's going to come to you after surgery 6 months and say, I can't reach the height of my marathons again. I'm a tiny bit short of breath. What has everyone done? But what people in that situation don't see, which we see this all the time, is the counterpoint. So the counterpoint is that marathon runner turns up. They don't want their operation. You delay it. They come back and they're not in the shape that they were. The heart has taken a bit of a hit. And then you do an operation, and afterwards, they never regain the initial stage they were 5 years ago because they waited. And we see that all the time too. But no healthy person wants to know that. What a healthy person wants is a guarantee that not only are they going to feel brilliant after surgery, but they may feel better, and there's no... And what people in that situation often forget is they're not presenting as normal people that have no disease and for a medical checkup. These people are presenting with a major physiologic disruption and a primary form of valvular heart disease, which again is only going to head in one direction. And so we looked at this group. We've done a lot of work actually here at UAB, the whole team, to say, what if we take these patients that are going to surgery early, take pieces of their heart, a biopsy, look at those under the microscope, send them for MRI scans, do all this advanced work at what are we going to see? And what we saw in patients that were as young as their 30s and 40s, and many of which were incredibly fit, was, somewhat alarming. When you look at the biopsies, they demonstrate evidence of a process known as oxidative stress. The hearts of 30-year-olds often have buildup of pigment protein and other elements such as lipofuscin and aging pigments, to where they have the heart that with buildup of things you'd often see in an 80-year-old. There's disruption of the heart at an ultrastructural level as seen by electron microscopy. And when you put them in an MRI scanner and you really look closely, not just I've had a quick look, it looks okay, but you start to do a more nuanced evaluation, you see evidence of a process called remodeling, and you see that fairly advanced. And alarmingly, after surgery, and this is not just the work done here, this is the work seen across the country and beyond, when you take these people and you operate on them, whether it's at a stage of mild symptoms or whether it's early, a significant proportion of patients will present afterwards with left ventricular dysfunction and remodeling that is not going to get back. So people with heart functions of 60 beforehand, and remember, 60 in mitral regurgitation doesn't necessarily mean the same 60 as normal. It's often falsely elevated due to loading conditions. But you will have people afterwards that will have ejection fractions of 30 to 40. And as of yet, we don't have the perfect predictor. So no, we can't tell the patient, you absolutely must go now because we see all this stuff and we think you'll do better. What we tell them is, we've got so much evidence that is accumulated now that bad things are happening even when you can't see them. But our duty really, and Dr. Lewis will tell you, because I tell you, he sends patients all the time back over to us where he's been sent them from outside. And they're sent for an operation, but this is a testament to having a high volume center where quality and outcomes are important, which is, I don't think this patient has severe MR. We'll bring them over, we'll do a nuanced evaluation, and we'll say, you don't have severe MR, you don't need an operation, we can absolutely watch you. And that population is rather large too, which are people which we can watch and wait till it becomes severe. That's very appropriate. But when it comes to the severe, truly severe, where all of us agree, we're on the same page, that, do you really want something to develop? Do you want atrial fibrillation and heart arrhythmias to develop? Because once those occur, the chance of you getting back to normal is low. Or do you really want elevated pressures in the heart? Do we want the heart to hit remodeling? Most of everyone would say no. I don't want remodeling to occur, and I don't want my biopsy to look like that of a 60, 70-year-old. And can you do this safely? Yes. But I'll tell you, when you have that conversation with a marathon runner, they don't see any of this. They tell you, I want a guarantee that, and so I'm very realistic with those people. I tell you, we have people that come in, Dr. we'll do the nuanced, they're good, we'll do the robotic mitral valve repair, they'll go home in like 3 or 4 days, they come back and they're doing great. But there's always going to be someone that comes back and says, well, my marathon time hasn't improved to world record standards, and I really shouldn't have had that operation. But that thinking, you're never going to be able to do, please everything and everyone. You must recognize that those people are coming to you with a life-threatening potential disease that could lead to heart failure that's irreversible. And for that reason, and the accumulation of evidence, all comers that will come to us with mitral regurgitation, primary, that can be repaired. We are going to offer repair to, even though, like you say, Dr. Bouchard, for the ones that absolutely do not want it, the key is follow-up. But not because it's any of us believe it's the correct decision to wait. We don't necessarily. But follow-up in the US is dangerous because lost to follow-up, because of things that we were mentioning now, geographical distance, ability to get to doctors. In Europe, where the primary care system and access to primary specialists is much more well developed, those patients turn up. In the US, it's not uncommon for people to turn up with primary mitral valve disease with completely burnt out ventricles, left and right side, because they have not been to a specialist for follow-up in the last 5 to 10 years since their disease was diagnosed. And then you're really in trouble. You're so far behind the curve at that point. You're wondering, what are the options for this patient that's never even going to get back to 20% of what they were, never mind what they were. So we have to take into our equation avoiding that. We want to avoid the worst case scenario. So the patient you described is someone that lives in town, that absolutely is going to check with their doctor, that's monitoring their symptoms all the time through a diary, that has access to maybe graded exercise testing intermittently to make sure they're not headed the wrong direction, that has specialists that can read nuanced scans and make sure they're headed in the right direction, and is really going to embrace the entire process, and they, for some reason, absolutely want to wait. That is the patient where we would say, all right, we'll watch you. The other category of people where that's important is, yes, we have minimally invasive options beyond robot, clips and this and that, the 80, 90-year-old. But, if a 90-year-old turns up and they've got no symptoms, or an 85-year-old and they've truly got no symptoms, I don't think anyone should be quoting to them early surgical repair literature and data. They're 85, 90 years old, leave them alone. If they develop a symptom, absolutely jump in and improve quality of life. But there's no need for this. And I've heard people have this conversation where, 95-year-old, you absolutely need your valve. That's just silly.
I think we could have a podcast just on the timing of surgery. One thing is for sure is that once you have severe mitral insufficiency, it's not going to get better with time. It's just going to progress and cause the left ventricle or the heart to have to handle that load of volume of blood that keeps coming back and forth, from across that mitral valve. And certainly the earlier, the better. And the repair is certainly the gold standard. So let's talk about a patient that has mitral insufficiency, Clifton. Let's say he wants to, he's scheduled to have a mitral valve repair robotic, by you at UAB. What should this patient expect in terms of, coming to the hospital? How long is the surgery? Is he home in a day or two? What is the recovery time and so forth? Can you describe to us a little bit what from the point of view of the patient?
So if it's just a basic mitral valve repair and you're a healthy patient, so we're the people we're talking about, degenerative disease, the marathon runner or the healthy person, and basically what they do is they come in the morning of the operation and they get a general anesthetic. We make a small incision in their groin, and then we basically put about 5 holes in their right chest, and then we repair their valve. It takes about skin-to-skin time, 2.5, 3 hours. If you look at anesthesia time, it's probably closer to 5 hours. And after we're done, they go to the what we call our CICU, or recovery room, and you stay there overnight. And then the next day you go to a regular floor room. And then when you go home is really dictated by two things. One is pain control. Most people think a sternotomy hurts a lot more than the a robot or minimally invasive. Early on, it probably hurts about the same. The first 2 or 3 days, the pain's probably just as intense. What's different about a right chest or robotic approach is that pain will dissipate a lot quicker than it will a sternal incision. So you got to have pain controlled. You have chest tubes, and they have to be removed. And so when you quit draining from your chest tube, you can pull those, and your pain's controlled. Your rhythm is controlled, and that's an important issue because AFib is almost ubiquitous in the mitral valve repair population. Once all those are organized, then you go home. The discharge days, probably the most common one is day 3, but it can be anywhere from day 3 to day 7, just depending upon those things. And that's maybe a day shorter than a sternal incision for mitral valve repair, but not a lot. Where they really start to diverge, a robotic or right chest approach, when you compare it to sternal incisions, is really at about the 10-day to 2-week mark. You can see a substantial difference in the functional capacity of a patient that's done without a sternal incision at the 10-day to 2-week mark as opposed to a sternal incision. And whether we release people to normal activities at 2 weeks. So if you have a sternal incision, whatever your operation is, you can't drive for a month, you can't lift heavy for 2 months. If you go through the right chest and use a robot for mitral valve repair, basically we'll let them do what they please in 2 weeks. They'll be a little limited by a little fatigue because any heart operation tends to make you tired. And so your functional capacity is limited a little bit by that. It hurt, you're still a little sore. But as a general rule, it's safe to do normal activities. So the operation is about the same length for us as a sternal incision. ICU is the same. The hospital stays a little bit shorter. But where you really see the benefit is on the back end where your recovery is a lot quicker.
Complications are relatively low. We've talked about mortality, maybe depending, of course, on the subject, of 1% to 2%. Risk of infection and everything. What are those risks?
So when you take heart surgery as a whole, I mean, the bad stuff you can have happen is heart attack, bleeding, strokes, infections, kidney failure, death. And if you look at a young, healthy person having mitral valve repair, you would expect the risk of one of those things happening to you to be less than 1% for mitral valve repair. Now that gets higher if you get older, if you get sicker, and not everybody is really healthy that has mitral valve repair. But it ought to be fairly low. And really the challenge when you do a robot or a minimally invasive is that you have to keep your results as good as they are through the sternotomy. Because what those results I just quoted you were based on sternal incisions. So it's really a very, very safe operation done through a sternotomy. And you've got to make sure that if you move to a different incision that you match those results. Will they exceed those results? I doubt it because those results are really good. What you got to do is be as good. If you look at benefits for minimally invasive robotic surgery, the only thing that's really been proven benefits, is that you tend to recover quicker to functional capacity. Discharge dates are earlier, so a shorter hospital stay. There is less blood use, and there's a lower risk of infection. And that's not an insignificant thing, the infection risk, because if you get a sternal wound infection, it's a life-changing event usually. You get an infection in the right hole in your right chest, your recovery is pretty quick,
Dr. Lewis and Mustafa, thank you very much for discussing the surgical repair of the mitral valve, particularly in the valve that has degenerative changes, the prolapsed mitral valve or myxomatous valve. I think this is a comprehensive review of the mitral valve repair. We'd like to have another podcast at some point to discuss the other pathologies, and particularly we're thinking about the ischemic mitral valve regurgitation, the regurgitation when the valve is infected, and also in patients that have rheumatic heart disease. So a lot for next time. Thank you, gentlemen.
Thank you.
Great.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.